licensed under 245, licensed under 245D, Chapter 245D, and then we also license adult day centers under Minnesota rules. Our licenses are all issued under Chapter 245A, the Human Services Licensing Act. And so, but today I'm going to talk to you very briefly for an overview, and I'm sure there'll be lots of time for questions about the 245D part of HCBS. And this is a challenging group of licenses that we oversee because of the diversity of them. We have well over 2,000, I think we have around 2,000 providers, but they serve people on all 4 disability waivers as well as elderly waiver. We license facilities, both residential and day programs, and then we also license services that are provided to people in their own homes or in the community, to somewhere between 60 and 75,000 Minnesota citizens. So it's a very broad and big group of providers and a big, broad group of service recipients who bring many unique needs to us. So I'll start with the types of services that we license as part of my PowerPoint. So the next slide. We have 2 types of services. One are basic support and the other are intensive. And these are defined. So if ever you're like, oh, does this include this or that? We can look to statute to make sure that we're really clear about which services we oversee. Maybe it's helpful to know from the get-go, this is many of the waivered services. It does not include PCA services, does not include home care, which is licensed by MDH. We have new licensing over at MDH for assisted living. So we don't license assisted living, but let's go through some of the services and how those might be of interest to you. So next slide. So on slide number 3, there are 7 basic support services, counting them out for bullets. I've highlighted the ones in red that are available and that we license for persons on the elderly waiver, because I think that's of most interest to many of you. So we license in-home and out-of-home respite. Typically, this excludes that out-of-home respite that's provided to children and family foster care provided through child protection. We also license adult companion services, but some of you might have funding for a senior companion program. And if you have that funding and you're providing that service, we do not provide oversight to that. So we do adult companion services funded through our waiver program. Personal support, another service provided to people living in a variety of settings this is a one-to-one type of enhanced service to give people that kind of engagement with a paid caregiver who is interested in what they want to do on a, might be taking them into the community to engage in community events or to spend time with them in their home. 24-hour emergency assistance and night supervision are really what they sound like to someone living in their own home, but who might need more supports. And it's not, the 24-hour emergency assistance and the night supervision is not the technology that gets paid for, it's the provision of the service. So again, waiver programs have access to paying for technology. We don't oversee that. We provide the oversight of the service. And then the next one is homemaker service. This is not the cleaning only service, but this is the service homemaker that comes with assistance with daily living, ADLs. So we monitor that service. A lot of providers who support the people in your communities provide homemaker service, often to a lot of people, because it'll be a regular service they provide to people, but not a lot of hours in a day, typically. And then the last service, which I call new, but it's not brand new, it's a few years old, ICLS, Individual Community Living Support. This is a very inclusive service for people who are residing in their own home. It's not available for people residing in any type of provider-controlled setting, but it's for people living in their own home, and it brings together in a bundled kind of way the services that a person might need. And also unique to this is that some of those services can be provided remotely. So it can include things like remote check-ins and use of technology to help the person live independently. So that's a service that's of great interest, I think, to many people who are aging. And one nice thing is you can bring in one paid provider rather than multiple providers, each doing their unique and distinct thing. You can bring in one provider, and then the person's plan details exactly what the provider will do. So they might do things that look like homemaker and adult companion and PCA, but all those things are going to be put into the plan, and then that one provider can provide all the services. The next slide starts with our intensive support services. And one of the reasons we made distinctions between basic and intensive is the levels of planned supports that need to happen, the types of documentation that occur, and we'll go through that a little bit later. And so I'm going to quickly go through these because I think these are not probably quite as much interest to you. We have intervention services that provide types of kind of behavioral support, and they can provide support to the person, but they can also provide support and training to caregivers. Our in-home support services are, again, for people who are living in their own home or their own family home. And this is where there's a number of services with different names and different titles. Waiver Reimagine over time is going to shrink these services down into fewer services, and that's going to be really nice for all of us, so we don't have to remember all these names, but some of them are still unique and distinct to one waiver, and so we have them all listed today, but over time we'll have fewer services available to all individuals on disability waivers. Slide 5, please. Then we have our residential supports and services, and these are services provided in facilities that are licensed by DHS or MDH. So SLS is provided in our licensed community residential settings, or CRSs is our acronym here at DHS. Our CRSs are similar to a foster home, but they're what we kind of call our corporate foster homes. The license holder doesn't live on site. Staff come in shifts and work in that CRS. And the community might call these group homes. So supported living services are provided there. If you're on one type of waiver, if you're on other waivers, it's called foster care. So those two services are typically the same, but they depend on the waiver that you're on. There's also services provided in ICFDD facilities. These are licensed SLFs by MDH and then certified federally as an ICFDD. It's an institutional level of care for people with developmental disabilities. We also have a handful of ones called residential services in an SLF, again, licensed by MDH, but they don't have this federal certification, and DHS does the oversight of services under 245D. And then finally, under residential supports, we have family residential services, and those are provided in family adult foster care homes or family child foster care homes. A new service, relatively new, on brain injury and CADI waiver, and soon next year, I think, coming to the DD waiver. again, within Waiver Reimagine, it's a little different. Integrated community support. And this is a provider-controlled setting. It's not a single-family home. And it's provided in a multifamily setting. So the way to understand these are typically, like we call these our apartment programs. So there's one or more apartments in an apartment complex where people are getting integrated community support, and the provider has more control of the housing and more control of that apartment than would meet a definition of own home. Often the provider will have an apartment that is provider apartment where they will direct services out of and engage with people. They might help people with meals, with medications, with engagement in the community, taking them out on activities. So that's our new service, integrated community support. And then quickly on the next slide are services that you might want to just think of as day and employment services. Day services are typically, although not always, provided in a licensed day service facility. So DHS licenses that facility, and then we give a license for what services can be provided in that setting, including structured day services, DT&H, and pre-voc. Again, with Waiver Reimagine, we're going to collapse some of those down in the next few years. And there's also employment services. These are newer services. They may happen in a day service facility, but they often happen in the community. So they include exploration, development, and then support services for people who are employed. On the next slide, I talk a little bit about our basic support in the service planning on slide 7. So helpful for you to know that there is a distinction between basic support and intensive supports about the type of documentation that must be required by statute. But also helpful for you to know is a person's plan really drives the services. And if there's something that you find missing within what you want to authorize as a service, it could be written into the person's plan, and then those are the expectations for the service. Excuse me. Under 245D, we really talk about this plan called a CSSP or a CSSP addendum. So a coordinated service and support plan, or a coordinated service and support plan addendum. It's such a mouthful. Just had someone say if they could have their wish, they would get rid of that long title. But we can't, so here we are with this. The CSSP is written by the person's case manager. So that is the person driving that plan. And that plan is then given to a provider with specificity around what, and if there are multiple providers, the plan should be very clear about what the expectations are for the provider. But it's also our expectation at the time that the provider receives that plan, which really should be before services are delivered, that the provider carefully reads the plan and would have any engagement with the person and their team if they felt there was any questions about what the plan is directing them to do, or maybe the plan directs them to do something that they cannot do. And when they do that review of the CSSP, this is the beginning of developing a CSSP addendum, which is the record that the provider has. So the provider has the CSSP in their file. It's directing what they're going to do. But as we would expect, most CSSPs are not going to have all the details that should be in place for delivering services. So then the provider starts enhancing this record by developing their own CSSP addendum, which is everything that kind of follows out and flows out of that CSSP. So You know, the CSSP might say that you come in and you do meal prep, but the CSSP addendum might have a lot of details about the meals that people like, how they want their food prepared, how they would want it stored. So it could have any number of things in an addendum that are much more person-centered to the person. So that CSSP is there, and then the addendum starts getting written on or before services begin. Then the provider, again, on or before services are initiated, needs to develop an individual abuse prevention plan. This identifies vulnerabilities that people may have and the action that the provider or others may take to minimize those areas of vulnerability. So that's important to have into place because that's a crucial document for staff. Within 15 calendar days of starting services, then preliminary CSSP addendum is developed. And then within 60 days of that services, the provider reviews and revises as needed the CSSP addendum. And this is documenting what services are going to be provided, how, when, and by whom, and who's responsible for overseeing the direction, delivery, and coordination of those services. A provider has to participate in ongoing service planning as directed in the CSSP. We don't specify what the minimum is, but we know that minimally people are meeting annually. There are no written reports that are required, but again, certainly within the CSSP or at any time, a person, their team, and the case manager can request written reports that are helpful for them to know about what's happening, what services are being delivered, or any questions or concerns. But with a basic support, there's no written reports that are required by our statute. On the next slide, I talk about the intensive support planning. It's a little different. Again, I probably left off a bullet about having a CSSP on or before the services are started, and that's important to, again, review that before you start any service. Also, the IAPP, Individual Abuse Prevention Plan, is the same. Then you have, again, complete that preliminary CSSP addendum within 15 days. But with intensive services, because they are more comprehensive and more engaged on a deeper and different level than basic supports, because there's usually training and habilitation and involved with intensive supports. Within the first 60 days, we need to do assessments for people about how they can manage their own care. And then they use those assessments to meet with the person and others on their team, figure out the scope of what services are going to be required. Important part is establishing desired outcomes and needed support. And those desired outcomes are written up and are deliverables that providers do. Service delivery preferences, and with specificity about how to engage with technology if that's being used by the person. On the next slide, I'm done. It was a really quick overview, but we do have a HCBS help desk, and there's always the HCBS licensor picking up the phone or listening to voicemail messages. So I'd always encourage you to call with any questions to our help desk, because you're going to speak with a licensor who's got really good working knowledge of HCBS, of the providers and expectations. And if there's any questions you have, you can certainly reach out to our help desk. That is a very quick overview of a very complicated program delivery. And our role at DHS in the licensing division with all of this is to oversee our providers, to help them maintain and sustain compliance with our licensing standards, to be available if they have any questions about how to do that. On our website, oh, I think I missed the one obtaining a license. I'm sorry, can we go to slide 9? When providers are interested in obtaining our license, the first thing we do is say, go to our website and read about our services, read about our licensing process. We have a pre-application worksheet, and we also have sample policies and sample forms. So they can go through all of these. You should be really well acquainted with this before they kind of click the button and say, yes, I want to apply for a license. So that would be one place if anybody's asking and wants more information, going to our website, learning more about what the services are, reading through our pre-application checklist, looking up the sample forms and the sample policies to get a flavor for what the expectations would be prior to submitting an application. People can apply. It's an online application. It does include the need to submit documentation along with a $500 non-refundable fee. All our license holders, whoever is owning and controlling that license application, does have to pass a background study. Subsequent staff who are hired will also have to follow that background study. We review our applications as received, meaning first in, first out. But we do have a significant waiting list right now. Not waiting, they're in a queue, waiting to be assigned to licensors to review. We've just had an incredibly big uptick in applications in the last 2 years. But as we process their application, once they're approved to provide services, then they go over to another part of DHS into provider enrollment and become a healthcare provider, enrolled provider. So it's kind of a 1-2 process, but the first process is to get a license. And then they go over to provider enrollment to become enrolled. And then depending on the services, when we license a program, we don't license them for all services. We license them for the services they've requested and that we determine they're eligible to provide. And then that will direct how they can enroll with provider enrollment too. So now I think I'm done and I can take questions.
I do not see any questions in the chat. So if anybody has any questions, I can stop sharing screen and we can go off mute and ask some questions. Yeah. One question did come in. Can you kind of sum up how an organization would determine if it's worth their time to go for a 245D?
Yeah, I would suggest an organization. Our license is issued on a statewide level, so you're not limited to any specific region or county, but most providers have a footprint that they want to work within. Maybe it's not just one county, but most providers work within a region. So I would reach out to those county agencies that you want to have a presence in and find out if there's a need for you to enter into their community. And if you did so, what services are they looking for? So every community, I think, has really distinct needs, and not every community has the same needs or desires for the same providers. So they might indicate there's certain populations that are less well-served, that have different needs, or there might be a service that they're really looking for providers to find more providers of. So I would suggest one of the ways is to find ways to engage at the local level to find out what local needs are. As the applying for a license has a cost. It costs $500. It's non-refundable, so you have to be prepared to pay that. And we assess if you're an appropriate provider through things like, are you competent? Do you understand the rules and the regulations? So it is a fee that you're not guaranteed a license from. And then an annual renewal fee is also always required. A minimum is $200. The licensing fees, and we have a fee schedule that you can find, but our licensing fee schedule is based on paid claims. So it goes up as you make more. So I guess that's one thing to consider. A big consideration right now for people is, do you have a workforce? So you might have a passion for doing this, but right now, one of the questions is talking about, do you have a workforce that'll be able to provide services to people? Certainly, we don't want people, going through all this work and then finding that they don't have a workforce. I think for many providers, really being clear about who your mission is, about who you want to serve, and creating that kind of expertise about who you serve best. I think those are really successful providers when they can articulate who they're there to serve and who they understand well.
Was there a question? Another question?
Yeah, well, it's kind of a comment and question. I'm from North Shore Area Partners in Silver Bay, and we got a 245D license in the end of 2019 to provide. We had already been providing housekeeping services for waivered clients, so we wanted to increase the level of service we could provide, so they increase and do personal cares and the ADLs. And so we went through the process. It was not that hard to get the license, but it was really hard it was a really steep learning curve to figure out how to manage it. So like I wish we had something like this, before we had gone into ours, and our county did not actually understand it any better than we did. And so when we were asking them for forms, they were saying, well, we've never had to provide those forms before, the CSSP in particular. And so it ended up being a very sort of a difficult, confusing process on both ends of it. And I'm listening here because I'm like, well, okay, I'm thinking maybe this will fill in some of the gaps, that we may still even have after 2.5 years. One of which is, so we've been providing housekeeping services that didn't require a license. We got the license so we could do the more services, but the only interactions we have with the county are for the people who are on waivers. If the question being, if we were only serving private pay, doing the exact same things, housekeeping and personal cares, to some degree, we don't do anything super high. It's not healthcare. We're not doing home health, although some people call it that. Does the 245D license, is it still required? Like we only have right now currently, I think maybe 2 or 3 who are actually on waivers, but we have 20, 25 clients at a time usually over the past couple of years, with less than 5 at any one time on a waiver. I'm just curious, I never, even when we were getting the license, I was never 100% clear where the license is necessary. Is it only when people are getting paid, being funded through the waiver, or do you have to have a license to do this kind of work for private pay people as well?
Yeah, thank you for that question. So a couple stuff. there was a thought when 245D was implemented that it would far-reachingly say, and it kind of says, it says as defined in, it doesn't say as provided by, the homemaker services as defined in our waiver plans, which could imply that it also applies to private pay. But the department doesn't have tons of interest in private pay, right? Like the department is mostly interested in people on waivers. So until you really want to provide services to that person on the waiver, certainly you could provide these services without a license, because there would be no data the department would have that would trigger anything.
Okay.
All that being said, I think you bring up a couple of good questions, and they connect to that first question about when should I get a license or is it worth it? Asking those questions about, am I really going to have that many people wanting homemaker with the ADLs? If I have few to none, maybe that's not an area I want to go in, and I want to just stay in the providing homemaker more as that cleaning service only, because that's what your community wants. But if you have enough people asking for, no, we want to do homemaker with the ADLs because that's what's needed, and the homemaker without it limits what you can do, and it falls short for people, I think providers just feel bad because they have to say, I'm sorry, I can't do X or Y. So I think once that first person that you say, yes, we're going to do this now, and it's going to be for a person on the waiver, then you absolutely need the license. But that would be a good question for people who are thinking about the difference between no license. I'm just an enrolled provider, right? I'm over at provider enrollment, but my enrollment is for homemaker cleaning only.
Right.
To that point, again, we do have those sample policies and forms out on our website. If you're doing these homemaker services with the ADLs, that's considered a basic service. So you want fewer policies and forms required. I appreciate that it is a learning curve, and I think that's a good feedback to your partners on the phone here. I think we should recognize that.
And sort of a follow-up with that, what is the particular difference between PCA services and 245D? I know PCA can be used for lots of different, besides waivered folks, it's just MA, correct?
Right.
That
So
was
a
another
couple
issue in the
differences.
beginning.
Okay. So the question is, what's the difference between 245D services and PCA?
Right, because if the definition of what you're physically doing is very similar. Sorry.
Okay. So policy can answer this better than me, but I'll give you a couple answers. One, there's limits on PCA, right? Like there's limited numbers of hours. You're not going to find those limits in a waiver program like you do with PCA. So often people on waiver programs have exceeded their PCA hours, and that moves them to the waiver. But that would be one reason. And then another reason is many of the services under 245D can be provided in a more, I'm just going to say seamless manner than PCA. There's not quite as many, okay, the PCA can do this, but now the nurse needs to come in and do X. And so we don't have those kind of dividers between that. So that might be more helpful to the person or their family, that they like that better. And then there's another distinction on PCA where the person or their caregiver has to be available to direct the PCA worker. That again is not required on waiver programs. So if the person's unable to direct their own care, they can still receive those services, depending on what services are authorized. But again, many of our folks with significant disabilities are unable to direct their care, so the plan directs the care. and the services provide the protections around which the care is provided. So those are some of the differences. But I think most of the time, the thing that moves people from straight PCA to waiver is the limited number, the hours are not sufficient.
Okay. Because initially we
The
had been,
ICLS, yeah, the ICLS is a service that aging could speak well to, but that's a service where they found in supporting people who are older, they were getting really confused or frustrated by having different people coming in doing different things, and that somebody showed up and they'd ask them to do something and they'd say, I can't, you know, like, you have to wait till Jill comes in because she can do that, I can do this. And that was frustrating to the seniors receiving services. You know, I can do your cleaning, but I can't do this next piece, even though I can. I can, but I can't, right? Because the rules won't let me. So ICLS was created in a way to try to get out of that frustration of, I've got a perfectly capable person here, but they can't go to the post office and get me some stamps.
right.
Because they're PCA and they can only help me with an ADA. Right. So ICLS and was trying to overcome that so that everybody didn't have these like distinct roles that just got really frustrating for the person receiving services. Still there's separation and there's roles, and the plan should just, you know, be very distinct about what services are available to the person, but it breaks down some of these barriers of like, I can do it up to here and now I can't do this. So I think the ICLS is that model. And then that is the model that also allows some use of remote technology to have conversations, to do things like reminders. So you could do like, or check-ins, you know, there could be well-being check-ins that you can provide and get paid for. There can be some medication reminders. There's different ways you can use technology. It can't substitute completely for the service. You can't just be on a Zoom call all day, but it certainly brings technology along with people in the home to support someone to remain in their home.
Right. So is this something, so I mentioned our county workers definitely wanted us to do this. There are no other providers in our area, which is why we pursued this. And so, so even though there's only a few people on the actual waiver, that was very important to them. And it turned out to be lots of other private pay people who were interested in it as well. But do they know all that they could, like, they only pretty much just give us basic homemaking and showers, you know, that's some medication reminder kind of things. But I know that there's other things that we could be, according to our license, you know, the companion, adult companion, or now with the ICL, whatever that you just were talking about. Is that a different code that we have to be like add to our license now, or like we're having some issues with the enrollment codes now that are what we're matching that?
Oh, that's a good question. So let's just say you have a 245D license right now, and you have homemaker is the only thing on your license. And the county approaches you and says they'd like to, could you do companion for some people? And you say yes, like we have capacity to do that. Yes, we think we could do that, but we don't have it on our license. What do? You call your licensor or you call our help desk and you ask to have your license updated, and we will add that service to your license. So typically we have a person on your license called your authorized agent. They'll either make a phone call or an email to their licensor or the help desk. They'll say, this is a specific service we want to add. We add that service to your license. There's no fee. There's really no, it's just going to be in writing through email to us. We'll add it to your license. Within 24 hours, it will display on your license in licensing lookup publicly. We'll also send you a new license. And then 24 hours later, you can go to provider enrollment and update your record and add that service to your record so you can now provide it and be paid for it. So you call us or you email your licensor, you
Right.
add it to your license. 24 hours later, the system burps and it's added to your license. At that point, then you approach provider enrollment and you say, I need to update my record. You add the service to your record. And once provider enrollment processes their part of it, you're good to go.
Okay.
So
Is
the
it
biggest hurdle is,
Go
excuse
ahead.
me, ask it.
Oh, I was just gonna say, is it typical that that enrollment process takes a long time? So in well, at the end of last year, I think, I tried to update an enrollment and it was over a month before I got a request for another document, and now it's been another month again. Is that typical? That seems to be where the block is right now. So there's some sort of can't bill for,
I can't speak to that.
because that's a different department.
I
Yeah.
think it isn't as quick as getting your license
Yeah,
updated.
that's that seems to be what it's doing. So I didn't know if
Yeah.
that was typical or not, or if there's some other
Yeah.
bigger reason why it was taking so long for us.
Yeah, I don't know, and I wouldn't want to speak to him. What I know about provider enrollment is you make a phone call and you get in a queue and it creates documentation of that I don't know how you contact them,
Well,
but once you
it's
contact them,
online now, so now everything is online.
okay, so it's all online. Okay, so
Yeah.
once you make that initial contact, it does create that record that you've
Right.
made that contact,
Right.
and they track that really, really well.
Yeah.
So I
Yeah,
don't
I'm
know if
hoping
that
it'll
means
go
they
back
can
to the
staff.
original date. Yeah, I'm just hoping
Yeah.
it'll go to the original date. Even though
Yeah.
we're months behind in billing for that particular service, but we can catch it up hopefully.
Yeah.
I don't want to dominate much more, but I have one other follow-up question. So on the PCA to the 245D side is, you told me the reasons between the different ones. And now from the 245D to the 144A, the Minnesota Department of Health, again, it seems like there's a little bit of overlap of like some of what's described in the Department of Health caregiving, the lower level of it looks exactly like what the 245D is doing. Obviously, then there's a little bit higher that starts getting more medically. How do you know where that break off is, where you would have to have that next license, or where we can operate in that sort of that gray zone there?
Providers are going to tell when they can no longer provide it, right? So what's the difference between helping someone shower and put on compression socks versus, oh, that's wound care and that goes too far, right? Like,
right.
People be very clear about what again, this is just the clarity that you need in your own policies, that you need to train your staff to, and that you need to make the person and their team aware of, like, this has now gone to a side that goes too far. But that would be, again, that example of that. Within ICLS, there's an ability for you to bring a team of people to the person. So as much as I was saying it's a more there's fewer silos, you still might say ICLS includes, we do have a nurse and she will come in and do wound duty, or it will be we do not, and we'll have to go to a home care agency to bring in that level of wound care or something. But certainly, like on ICLS, you can do things like med management, medication monitoring, setting up meds, things like that are helpful for people that you wouldn't necessarily have the ability to do with PCA.
So is it really kind of, we do have a nurse on staff, an RN, who oversees anything that gets close to that sort of medical management edge, but the license isn't, she's not 100% clear where that breakoff is. It's kind of her personal comfort level rather than what the license is saying, which is, I'm okay, I trust her judgment, but I don't, it's been hard to read in the license exactly what is that maximum you can go to.
So on on the DHS side, we don't really say that people have exceeded their
Okay,
licensing authority. It is that person holding the license who says,
right,
this is too far.
okay.
So
So it
it's
is
kind
up
of
to
her
her
obligation.
pretty much.
Yeah, and if she's
Okay.
comfortable training staff and we allow that. We allow
Okay,
staff to be trained to do medication management, to do
Yep.
medication administration, to do medication treatments or healthcare treatments. We allow staff
Okay.
to be trained. We do say, depending, again, like I think we're getting into like more intensive services that you probably typically don't provide,
right,
but then it gets to be a point where a nurse will say, who's on your staff, like, this is not okay. I will not delegate my authority any farther than this because I don't think I should.
right. Okay, so that's what we've been doing is pretty much
MDH,
giving it to her.
MDH has MDH's licenses are much more specific, and I think they have a lot more daylight between some of these about nurses and what nurses can and can't do under home care, under assisted living, under any number of licenses that they issue. But that's because they're the Department of Health.
Right.
And we're the Department of Human Services, so we have we look at life a little differently. And we
Yeah,
look at
well-
life more in
Well, that helps actually just explain it because I've just have been unclear if it's just something that we're not understanding or if it actually isn't there. And it sounds like it's not there. So it's judgment call and up to a certain point. So.
I have a question. How can I find out what services the license is good for?
Oh, well, there's a really easy way to go to the DHS public website and find the licensing division. And we have something called licensing information lookup. And you can search by the name of the provider or the county or the type of license. And then when you click on their license, when you find them and you click on it, it will list the services they're currently licensed.
So, another question related to that, there's actually 3 levels of homemaker, correct?
There's several types of homemaker. So I won't be able to say, I bet you're correct, but I don't know. I know there's several, yes. We only license one. Yeah.
So we can be licensed for the homemaker cleaning and the homemaker ADL, but if we don't have people that can do the personal cares, so then we're not licensed for that one, correct?
Not quite sure how that question came in and how let's see. If you're looking to look at your record and when you need a license, that would be one way to do it. When you're looking at your provider enrollment forms, it will tell you when you need a 453 license. So if you pull up your those forms from provider enrollment, and you look at all the different types of homemaker, because there's just a bunch of them, it'll be clear when you need a D license is required. The way we've set it in D, and I'm not sure it always lines up just perfectly with enrollment, but we have said the homemaker as defined under these waiver plans, providing, but if you're doing cleaning services only, you do not require a license. Also, if you're licensed by MDH under 144A, You shouldn't need our license.
Yeah, no, it was a, 45D that we just renewed, and the situation is that we had, the executive director left, and then we
Yeah.
had we renewed the license, and I'm like, I don't think we need that anymore, and
Yeah.
trying to
So
figure
the
out-
best thing, yeah, the best thing I'd suggest when you've just got some free time is to call the help desk and to ask, and you'll speak to a licensor. They can pull up your license, figure out what you have, and then you can start sharing, like share with them the billing codes that you're using, and they can give you clarity around it. That's what I would suggest, rather than I'll give you the wrong information, or I'm just going to be like unhelpful. So call our help desk and be prepared to give them, they can pull the license up so they can see the services you're licensed for, and then tell them what you've been billing for in the last 6 months or so. And it's with the modifiers. The modifiers make a difference too.
right, so that
And then
number is,
then they can sort it out, and then you can communicate next year when we send out an invoice. If you don't want to pay it, just tell us you want your license to close, or if you want to close it today, you can call us and we'll close your license too. Unfortunately, once you've paid it, we can't refund it, but sorry.
so the help number is 651-431-6500. Thank you, Dan.
6624.
Okay,
Yep.
all right, I
Yep. Are we getting kicked
Thank you.
off?
We have another question in the chat quick. We will plan on sending out the recording and the PowerPoint also, just so everyone can have that with them. So the next question is, what happens if a 245D provider does not do the 245D paperwork? Specifically CSSPA, IPP, etc.
So those are standards that you need to do. If you haven't been doing them, I would suggest you call and ask to speak to your licensor. If you don't know who your licensor is, call our help desk. They can tell you who it is. And you need to get on board with getting into compliance. Don't go backwards and try to make something up that you haven't been doing. Be honest with your licensor and say, I haven't been following these regulations and I want to get things lined up and start doing them right, and they will tell you how to start doing that. What would happen? Eventually, we would take action against your license. It usually starts with a correction order, but it can immediately be a conditional order or revocation. It kind of depends on what we find, but if we see people are, asking for a license, billing for services, and not doing anything, then we do take action against their license. And it ranges from correction orders to license revocation.
So in this instance, I believe they are the lead agency provider struggling with getting the CSSPA back from other community providers they're using.
Oh, just document that you can't get that, and then you do the best you can. But you're going to do an IAPP. That's your responsibility as the provider. The individual abuse prevention plan, that's your responsibility. And then developing the CSSP addendum is your responsibility. So if you can't get that written plan from the local agency, then you're going to develop your own written plan based on conversations with the case manager, with conversations with the person or their caregivers, and you're going to develop your plan. And you just put it in the documentation that, you requested it and you couldn't get it. But I think that's another conversation like to have with policy, that you can't get plans from people.
That was the
We
last.
don't hold.
Go ahead.
I just And we're understanding, like, you can't control other people, right? So we hold you responsible for your own actions, but other people, just make note of how difficult it is, and we will understand that.
There are no other questions in the chat right now. Does anybody else want to come off mute and ask any other questions or throw one in the chat? We'll give a few more minutes around that.
I have a question. So if you are just doing housekeeping, you do not need a 245D license. What services, specific services, fall under the 245D licensure versus a PCA? What's in the ADL versus what a PCA can do?
It's probably a good question to drop to the policy division rather than the licensing division as much. Again, I think it's often intensity or duration. I think homemaker with ADLs is really meant, the primary focus of the service is the homemaker, but it allows you to do some ADLs. PCA is really focused on ADLs as opposed to, there might be something that you sort of pick up along the way and you're not going to really call it homemaker. So I think it would be a good conversation for you guys to talk with policy staff about some of those distinctions.
I am not seeing any more questions come in, Jill. So do you have any closing thoughts before we close out the meeting that you would like to offer?
No, I appreciate being invited. We should probably, reach out and do this more often instead of waiting so long. And maybe next time I'll figure out the Zoom better. So I wish I could have aid you all. But I appreciate the conversation and time together. And we appreciate hearing from providers and any issues. So again, reach out to our help desk anytime, and we'd be happy to talk to you guys. Thanks so much.
Thank you, everybody, for joining us today.